Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be going over endocrine disorders. We're going to be covering diabetes mellitus, diabetes insipidus, SIADH, Cushing's, Addison's, all that good stuff. We're going to be covering endocrine disorders. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give a thumbs up now. Subscribe to my channel if you haven't done so already. Be sure to check out my website. There you will find plenty of resources, including audio lessons, and you can sign up for private tutoring sessions and next generation NCLEX review sessions. The great news is, well, great news for you, not so much for me. You know, my vacation's winding down to an end. Summertime's almost over for me. First day of school for the kids. My calendar is now open. So I've opened up my calendar for September. So if you'd like a private tutoring session or you want to sign up for next generation NCLEX review, do it now because I book very quickly. Those of you who have been following me, you already know that. So go ahead and go to the website, nexusnursinginstitute.com. I've already said this to you in, I think it was a Kahoot, but I just want to give you a heads up. Just keep your eyes and ears open in the next upcoming weeks. I do have a Nexus Nursing test bank that will be coming out that is going to prepare you for NCLEX. Again, guys, I don't have access to the exact questions, so you're not going to get the exact questions that you'll see on NCLEX. But you want to know what? You'll see questions like the type of questions that you'll see on NCLEX, the important things that you need to understand. Now, what I'm going to do is I'm going to give away 50 memberships to this program that I have rolling out. 25 for LP and LVN students, 25 for RN students. And it's going to be a competition, but I'm not sure how I'm going to do this yet. I'm still thinking about it in my mind. But if you win, you're going to get access to the questions. You're going to get to meet with me once a week to go over any questions that you may have, any questions that you thought were tough or you have concerns about, things that you think I need to change. You're really going to be like my beta testers before it truly rolls out. But it gives you access to me once a week where we're going to go over anything you want to talk about. This is going to be coming out in the next couple of weeks. So just keep your eyes and ears open. I'm really excited about this because I put a lot of work into it. Now, eventually, I'm not going to have it at the beginning because this takes time. But what I'm going to do is those questions that you're going to practice and have rationales for, you're going to be able to click on a little button. And when you click on the button, I'm going to be talking to you about that rationale and just remind you of important things you need to keep in mind. And, you know, even though the questions like this, on NCLEX, it may be like that. So it's the same concept, but they may flip it and you need to keep your eye out for that. But it takes time because each question is individualized, right? So just keep your eye out for that. I feel like there's something else I got to say to you about housekeeping, but I don't remember, so I'm going to keep going. Before we get started, as always, you guys know I start off my videos with a prayer. If you're not into that, just fast forward. If you are, go ahead, close your eyes and bow your head. Make sure you're not operating heavy machinery. Father God, thank you, Lord. Thank you, Jesus, for all that you've done for us. Thank you for your grace and your mercy. Thank you for waking us up this morning. Thank you for the breath of life in our bodies, Lord. Father God, thank you for the children that you've protected that have gone on after school, their first day of school. Lord, I pray that you please protect every single child, Father God. Protect every single child on that campus, every single adult on that campus, every instructor, every teacher. Lord, I ask that you please help these children to learn to the best of their capabilities, Father God, and keep them. Lord, I pray for every single viewer, listener right now that came to this channel for whatever their specific reason is. Lord, I ask that you please help them to be successful in answering test questions. If they're studying for NCLEX, please help them, Father God. Please give them the discipline to study the way that they need to, Lord, or help them understand that the way that they've been studying is not working, Father God. And Lord, I ask that you please just give them clarification, Father God, and let them find the correct way for them to study. I ask that you please bless the people who are supporting them and encouraging them and rooting them on, Lord. Please encourage them. Don't let them give up, Lord. I ask that you please help me to deliver this information in a way that is palatable to the student, that they can understand, they can digest it, Father God, and they can learn to think critically and answer the questions correctly. Lord, thank you. Thank you for all you've done and all you continue to do in our lives. In Jesus Christ we pray. Amen. All right, guys, let's get started. First question. The nurse is reviewing several physicians' orders for a newly admitted patient diagnosed with diabetes ketoacidosis. Which order should the nurse immediately question? A, IV infusion D5W to run at 100 milliliters per hour. B, IV infusion of KCl 10 MEQs and 90 mLs of sodium chloride. C, administer sodium bicarb if the pH is less than 7.2. Or D, administer insulin per infusion protocol and adjust the dose based on hourly glucometer readings. What do you guys think? And guys, the correct answer is A. IV infusion of D5W to run at 100 milliliters per hour. So if we go back to the question, it says which order should the nurse immediately question? Whenever you get a question asking you what you're going to immediately question, what do you need to clarify? Which requires which requires further follow-up? Which one requires confirmation? Which one requires further teaching? All of that verbiage that's being used, they're really asking you which one is the wrong thing to do. And the correct answer is here. A, IV infusion of D5W. Go back to the question, and this patient is in diabetic ketoacidosis. Their blood sugar is too high. Why the heck would we give them D5W? You want to know what that D in D5W stands for? Dextrose. Sugar, right? So we're not going to do that. Now, our other choices, IV infusion of potassium chloride, 10 MEQ. Nothing's wrong with that because remember, insulin drives potassium into the cells, right? So nothing wrong with that. Next, administer sodium bicarb if the pH is less than 7.2. What's wrong with that? Remember, pH is 7.35 to 7.45. That is your normal therapeutic range. So if it's at 7.2, yeah, the patient's more on the acidic side. Nothing wrong with that. And then D, administer insulin per infusion protocol, adjust the dose based hourly on the glucometer readings. Yeah, that makes sense. And usually the facility protocol is going to be for blood sugar 250 or less. Why? We want to avoid seizures. So B, C, and D, all of these are correct things that we would expect to be done, but you're going to question the order if you have an order to give the patient dextrose and they're in diabetic ketoacidosis. We're not going to do that. This patient that's in diabetic ketoacidosis, you expect for them to be started on, half normal saline or normal saline. Why? If they're DKA, this patient's also going to be at risk for dehydration because we've got a whole lot of polyuria going on. So we have to start with fluid resuscitation. Remember, when it comes to Maslow's hierarchy of needs and the type of priority patients, what are the type of priority patients? The patients who are at risk of dying. Fluid electrolytes, lack of fluid electrolytes. Why? Their body can go into shock. And we know if that patient's in DKA, they're urinating all over the place. They're going to be at risk for dehydration. So we absolutely want to provide fluid resuscitation. Now, we're going to provide fluid resuscitation and we're going to give the patient insulin because their blood sugar is high. But once it gets down to that number, I already mentioned it, 250, what are we going to do? We're going to start adding glucose to the fluid. Well, Professor D, what do you talk about? This patient's glucose is so high. We've been giving them insulin and we've been giving them fluids because we want to give them fluid resuscitation. Why in the world would we give them glucose? Here's why. When the patient's glucose is so high and we're giving them insulin, right? We're getting that blood sugar down. Once we get it down to 250, the reason that we also still give them a little glucose, we don't want that their, serum glucose level to drop quickly because that quick drop in glucose levels can cause what? Seizures. So even though the sugar is still too high, we're still giving them a little bit of glucose in the fluid because we don't want them to get a seizure. But that's once the glucose is down to what? 250. 250 is that magic number. So anyway, I kind of got off course. The point of this question is to know if this patient's in DKA, we're not giving them dextrose. They're going to have half normal saline or regular normal saline. And once that glucose gets down to 250, then we may add some glucose because we want to prevent seizures. Okay? All right. Next question. The nurse is teaching a patient about diabetes management during stress or illness. Which instructions should the nurse provide? Select all that apply. All right. How do we treat select all that apply as true or false? You guys know that. Let's go. A, call the healthcare provider if unable to tolerate food or fluids. True. Why? I want you to think about it. This patient, go back to the question, they have diabetes and is during time of stress or illness. What do we understand about the correlation of blood sugar and stress or illness? Blood sugar goes up. When you're stressed or you're sick, and sickness, that's a stress on the body. So you have a traumatic emotional stress, psychological stress, physical stress. It can cause your blood sugar to go up. A patient who's already diabetic, their blood sugar's up, and then you put stress or illness on top of it, what can happen? Possible DKA, right? Polyuria, patients already at risk for losing fluids, and then on top of that, they can't eat or drink to replace. We have a problem, right? So we're going to tell them to call the healthcare provider. Why? We want to prevent dehydration. B, monitor glucometer and urine ketone levels daily. That's not enough. The patient's diabetic and they're sick, and that, which means that glucose can be extremely high. We're going to do it much more than daily, about every 3 to 4 hours. All right. C, continue to take anti-hyperglycemic agents as ordered. Absolutely. Why? Because during times of stress or illness, we expect their blood sugar to go even higher than normal. So true. D, when taking an oral hypoglycemic agent, administer insulin in addition to hypoglycemic medication during times of illness. False. Here's the thing. Insulin may be necessary, but it may not be necessary. Right? So when it says take oral hypoglycemic medication in addition to insulin, that's absolutely false, because sometimes insulin absolutely is necessary, but not always. So that's what makes it false. It's really based on the patient's condition. So A and C are the correct answer for those two. Which lab result or clinical manifestation would indicate that a patient in diabetic ketoacidosis is responding appropriately to treatment? A, dry mucous membranes and flat jugular veins. B, moist skin and skin turgor less than 3 seconds. C, serum potassium level of 3.4 milliequivalents per liter. Or D, arterial blood gas level showing a pH of 7.2, PaCO2 of 25, and bicarb of 19. What do you think? And the correct answer is B, moist skin and skin turgor less than 3 seconds. Why? So we know in diabetic ketoacidosis, the patient's blood sugar is so high. We know they're at risk for dehydration, all that polyuria, right? So how do we know the patient's getting better? Okay, we want to see signs of the opposite, right? The blood sugar not being low, patient not being dehydrated. Look at our choices. B, the skin being moist, because when you're dehydrated, your skin's not going to be moist. It's going to be dry, right? Skin turgor, when you're dehydrated, skin turgor is going to be less than 3 seconds. Skin turgor is going to be more than 3 seconds, not less than 3 seconds. So that is your correct answer. Why? We're seeing that the dehydration is improving. Look at the wrong choices. A, dry mucous membranes, dehydration. Flat jugular veins, dehydration. Look at C, serum potassium of 3.4. Normal serum potassium is what? 3.5 to 5. 3.4, this patient's at risk for metabolic acidosis, that patient with DKA. That doesn't show the patient's improving. Choice D, arterial blood gases showing, look at this, pH is 7.2. Remember, regular pH is supposed to be 7 point what? 3.5 to 7.45. Here goes 7.20. Patient's acidotic, right? CO2 25. What's the normal CO2? 35 to 45. And then bicarb 19. That's also too low. So the only one here that's showing that the treatment's actually working is going to be choice B. The neighbor of an elderly type 1 diabetic client brings the client to the free clinic because the neighbor is no longer able to continue administering insulin injections to the client. When advocating for the client, the nurse should take which action? A, contact Adult Protective Services. B, inquire about possible family members that can continue the insulin injections. C, contact the facility social worker. Or D, encourage the client to return to the facility every morning for injections. And the only correct answer here, guys, is C. Contact the facility social worker. So if you go back to the question's asking which one shows you advocating for that patient. The only one where you're advocating for that patient is contacting the facility social worker. Why? What is the job of the social worker? The job of the social worker is to what's the word I'm looking for? I'm sorry, guys. I'm still on vacation mode. It's going to take me a couple weeks to get back to normal, but reaching the client's needs by getting them resources in the community, right? Now, in this question also, it says that the patient's a type 1 diabetic. Whenever you see type 1 diabetic, automatically, you need to think in your mind, this patient's insulin dependent. They have to get insulin. And if they don't, they're not going to live, right? Look at the other choices. We have A, contact adult protective services. Adult protective services, you're going to contact them when you suspect adult abuse, something like that, right? Either actual or potential. That's when you're going to contact them for an investigation regarding abuse. Choice B says inquire about possible family members that can continue insulin injections. Even though there's nothing wrong with doing that, again, the question's asking about advocating for the patient. When you inquire about family members, all you're doing is collecting information, which again, that's nothing wrong. There's nothing wrong with that. When you collect information, you're doing what? You're assessing. Anything you do to get information, it's an assessment. There's nothing wrong with that, but that's not advocating. Advocating is actually doing something for your client. Choice D, encouraging the client to return to the facility every morning. You got to be kidding me. This patient is a type 1 diabetic. They are insulin dependent. You know how every time you put something in your mouth, right? You put something in your mouth, automatically, you have insulin. It's endogenous. It's in your body. And that insulin is released from the beta cells from the islets of what? Langerhans, in your pancreas, right? And it releases insulin. Your body does that naturally. The patient that's a type 1 diabetic, those beta cells are dead. They are not working. They have to get an exogenous source. Exogenous, that means an outside source of insulin. So if that patient comes every morning, okay, great. They got the insulin for breakfast. What about lunch? What about dinner? Right? So the only correct answer here, guys, is going to be to contact the facility social worker. We need to get a resource for this patient so they can get the help that they need. Which nursing diagnosis is least likely to be included in the nursing care plan of a patient whose labs indicate an elevated growth hormone level? A, decreased fluid volume related to polyuria. B, sleep disturbance related to soft tissue swelling. C, communication deficit related to speech disturbance. Or D, disturbed body image related to undergrowth of head and extremities. And guys, the correct answer is D, disturbed body image related to undergrowth of head and extremities. Go back to the question, and the question's asking us which nursing diagnosis is least likely. That means we would not expect to be included in the care plan for a patient with elevated growth hormone level. So look at D and look at how this is worded. Disturbed body image. Okay, nothing wrong with that yet, because if somebody has elevated levels of growth hormone, they absolutely may have disturbed body image related to undergrowth of head and extremities. Yeah. If that GH is elevated, what will we see? An overgrowth of head and extremities, not undergrowth. That's what makes it wrong. We would expect to see that patient have big hands, big feet. They may have a big face because of the skull, the cranium, right? So that's what we expect to see, overgrowth, not undergrowth. All of the others correct. Decreased fluid volume related to polyuria. Why is that? GH antagonizes insulin. Did you know that? Growth hormone antagonizes insulin. So if insulin's not working the way it's supposed to be working, the patient would be hyperglycemic. What happens when the patient's hyperglycemic? Polyuria. What happens when they have polyuria? Dehydration. Right? So that makes sense. Choice B, sleep disturbance related to swelling of soft tissue. That makes sense, because if the patient has elevated GH, in elevated GH, a growth hormone, those bones get big, but also what we'll see is those tissues get big as well. And so the patient may have sleep apnea from not total occlusion, but maybe partial blockage of the pharyngeal tissue because of all that sweating. I hate this. And guys, I don't edit my videos. I make a mistake, I just keep going because I'd be here forever. All of that swelling, the tissue swelling, it's edematous, and it may make it harder for that patient to breathe when they're sleeping, because think about it, when you're sleeping, you're lying down. And when you're lying down, you got the abdominal girth pushing on your organs, especially your lungs, which makes it harder for it to expand, it makes it harder for the patient to breathe. So that's why they may have sleep apnea. So that is true. And then choice C, communication deficit related to speech disturbances. Yeah, why did they gonna have speech disturbance? Again, that swelling of the tissues, including the esophageal, but also the pharyngeal, but also the tongue. They may have an enlarged tongue, and that can cause speech disturbances as well. So the only correct answer here, guys, is D. The nurse is caring for a patient with diabetes insipidus. Which nursing actions would be most appropriate? Select all that apply. How do we treat select all that apply? As true or false? 1, monitor glucometer readings before and after meals. False. Be very careful. The question said diabetes insipidus, not diabetes mellitus. Those are two separate disorders. In diabetes mellitus, that's when the patient's blood sugars increase. But in diabetes insipidus, that's where the patient's urinating all over the place. In diabetes insipidus, the patient has a lack of ADH. They have a lack of anti-diuretic hormone. Anti-diuretic hormone is what makes you hold on to your fluids. When you don't have enough of that, you're like Oprah. You get urine, you get urine, you get urine. Everybody gets urine. You are urinating all over the place to the point of dehydration. Here's the crazy thing about diabetes insipidus. Your urine output is increased. Your urine osmolality is decreased, because even though you're urinating all over the place, all of those particulates like the sodium is what? In the blood. So the urine specific gravity is down. But if you check the patient's serum osmolarity, it's up. Why? Because again, all those particulates that should have been the urine stayed in the blood. So even though urine output is up, urine specific gravity is down because there's no particulates in it. It stayed in the blood. And when you check the blood, you check the serum osmolarity, you'll see it's up because all those particulates stayed in the blood and not the urine. Okay. So anyway, I think I gave you the answer to the next one, but moving on. Where was I? Yes, B. Monitor hourly INO flow sheets. Absolutely. Because again, in diabetes insipidus, it's all about urine output. This patient is urinating to the point that they're at risk for dehydration, severe dehydration. So we need to keep an eye on that. If we're treating the patient with diabetes insipidus, how do we know if they're getting better if we're not doing INOs? As the patient's getting better, we should see the urine output start to decrease. That's how we'll know the patient's getting better. So that's true. How about C? Monitor hourly ketone levels. False. Ketone levels, that's for diabetes mellitus. We're talking about diabetes insipidus. Make sure you read very carefully. False. How about D? Administer desmopressin acetate as ordered. True or false? True. This medication, guys, it's given orally, IV, or nasally. And basically, it's an ADH replacement because remember, in diabetes insipidus, the patient doesn't have enough ADH. That's why they're urinating all over the place. So this medication is an ADH replacement to help decrease that urine output. So that's true. And last, E, assess for clinical manifestations of, that's not last. E, assess for clinical manifestations of hyperkalemia. False. Guys, remember, this patient is urinating all over the place, but the particulates that should have been in the urine, it's in the blood. What are we going to be looking out for? Increased sodium. Remember, the urine specific gravity is low. Okay. We'd be concerned about hypernatremia because all that sodium that should have been in the urine has remained in the bloodstream. And that's why the urine specific gravity is low because there's no sodium there, and the serum osmolarity is high because the serum has stayed in the sodium has stayed in the blood, right? So E's false. And last, perform daily weights. Of course. Why? What is the number one way to accurately measure how much fluid a patient's holding on to? It's not skin turgor. It's not INO. It's daily weights. Daily weights. That is the number one way to measure how much a patient is holding on to measure fluid loss. Daily weights. So absolutely. You're going to do that for this type of patient, and also like a patient who has CHF that's holding on to fluid, and you're trying to make them, not hold on to the fluid. You're going to be doing daily weights. Any patient that is holding on to fluids, you're going to be doing daily weights, including diabetes insipidus. The nurse is caring for a male patient with a pituitary tumor. After 2 weeks of unsuccessful treatment, he developed syndrome of inappropriate antidiuretic hormone secondary to the original tumor. His clinical manifestations include increased thirst, headache, weight gain, fatigue. His serum sodium level is 129 milliequivalents per liter. Which order should the nurse expect when treating this patient? A, elevate the head of the bed between 30 and 40 degrees. B, administer vasopressin IV push. C, restrict fluids to 800 milliliters daily. D, administer sodium chloride intravenously. And the correct answer is C, restrict fluids to 800 milliliters 800 milliliters daily. So we're talking about SIADH. It's the opposite of diabetes insipidus. So in diabetes insipidus, you didn't have enough antidiuretic hormone, and that's why you're urinating all over the place. Well, in SIADH, you have too much antidiuretic hormone, and you're holding on to all your fluids, right? So that's why we have to restrict fluids. And you should expect the fluids to be restricted, between 800 to 1,000 milliliters per day. Look at the wrong answer choices. A, elevate the head of the bed between 34 to 40 degrees. I think I meant to say 30 to 40 degrees, but whatever. The point is, no. The head of the bed is going to be flat. If it's not flat, it's not going to be higher than 10 degrees. Why? We want to increase the venous return to the heart. So that head of the bed is either going to be flat or elevated to only 10 degrees, no higher than 10 degrees. Choice B, administer vasopressin IVP. We just talked about this. Vasopressin, this is an antidiuretic hormone that would make it worse in the patient that has SIADH. So we would not do that. And then D, administer sodium chloride IV. Why would we do that? This is a hypertonic solution. Okay, we're gonna give if the patient was hypernatremic, if it was severe, less than 120, but that's not what we're dealing with. So we absolutely would not do that. Your only correct choice here, guys, is B, restricting fluids, because they're already holding on to too much fluid. Is that proper English? Too much? They're holding on to too many fluid? They're holding on to too much fluid. I think it's the second one. They're holding on to too much fluid. Please let me know in the comment section if I have it wrong. I'm sorry. But you know what I mean. Where you're going to restrict the fluids between 800 to 1,000 mL, depending on what the healthcare provider orders. Next question. The nurse is planning for a client diagnosed with diabetes insipidus. Which clinical manifestation should be expected? A, polyuria. B, diaphoresis. C, hyperglycemia. D, weight gain. And I know you guys all know this answer because I have explained this to you a million times. A, polyuria. Diabetes insipidus, you are urinating all over the place. So what does that mean? You're at risk for dehydration. Polyuria, that's what's happening. In diabetes insipidus, you do not have enough antidiuretic hormone, so you're releasing too much fluid. Diaphoresis, I just threw that in there because I needed a clinical manifestation. That's when you're sweating a lot, by the way. C, hyperglycemia, that's associated with diabetes mellitus, not diabetes insipidus. And then D, weight gain. The patient that has diabetes insipidus, remember, they're urinating all over the place. If anything, we'd see weight loss and not weight gain. An adult client admitted with hypotension, bradypnea, bradycardia, hypothermia, and a lethargy. The client's daughter reports that the client has not been taking his prescribed thyroid replacement hormone. Which action should the nurse take in order of priority? So if you're in front of the computer, you would have to take your mouse and put the nursing actions in order. So what are you going to do? Here are your choices. Administer oxygen, replace fluids, place a warming blanket on the patient, administer thyroxine as ordered. In which order would you put these nursing actions? I'll give you a second to think about it. And the correct answer is exactly how you see it on the screen. Exactly how you see it on the screen. So you walk in your patient room, the blood pressure's down, breathing's down, heart rate's down, temperature's down. They're not easy. You can't arouse them easily. You know, they're have lethargy, right? They're not easily aroused. And the patient's daughter reports that they have not been taking their thyroid replacement hormone. What does that mean to you? That means you know that this patient had hypothyroidism. That's the only reason they would need thyroid replacement hormone, right? So they haven't been taking this. So that lets us know this patient is most likely experiencing myxedema coma. Myxedema coma is hypothyroidism times 1,000. Okay, this is what we're suspecting happening. So the first thing you're going to do is administer oxygen. Why? We don't care about anything else if our patient's not breathing. And in the question, it says the patient has bradypnea, decreased respirations. Respirations should be between 12 to 22. After we confirm patent airway, patient's got oxygen, then we're going to replace fluids. Because guys, whenever you have to think about priority, you got to think about what is going to kill my patient the fastest. So our first priority is oxygen. Without oxygen, your patient's dead. Forget everything else. After we've established that, fluid and electrolytes, right? Replace the fluids. And we know that this is important. Think about it. Hypotension. We're going to need to replace the fluids. We will need to keep that vascular space open. C, place a warming blanket on the client. Yep, they have hypothermia. The temper, I put warming blanket. I'm just joking. I meant cooling blanket. I need to fix this. Cooling blanket. Wait a minute. Let me think about this, guys. They have hypothermia. No, I was right. They have hypothermia. So they're cool. I'm sorry. They have hypothermia. So they're cool. Yes, warming blanket. I'm sorry. I was correct the first time. So we're going to put a warming blanket on them because they have hypothermia. They are cool. I want you to think about it. If you're cold, what are you doing? You're shivering. Guess what? In order to shiver, your body has to have that energy to make you shiver. That increases the metabolic demands. Do you think that patient with hypothyroidism has that energy? They can't meet that metabolic demand. Absolutely not. Absolutely not. They have hypothyroidism. So if they have hypothermia where they're cool, we need to warm them, because if they're trying to warm themselves, they're doing this, they're shivering, but look at what else is going on with them. No, their body can't handle it. They cannot handle it. We need to decrease that metabolic demand. So we're going to, instead of their body doing this, shivering to try to keep them warm, we're going to do it for them. That's why we're putting the cooling blanket on them. Okay? Last, administer the medication that they haven't been taking. So the first thing we're always going to do, guys, whatever is physiologically wrong with the patient, we're going to fix that. We're going to correct that. ABC, airway, breathing, circulation. Airway breathing comes first before circulation. So we're going to make sure the patient has a patent airway. Then we're going to care for everything else. When it comes to priorities, think about Maslow's hierarchy of needs. What falls under physiological integrity? Airway, breathing, circulation, abnormal vital signs, abnormal labs, fluid and electrolytes, signs and symptoms of dehydration, glucose, signs and symptoms of stroke, signs and symptoms of seizure. All of those fall under physiological integrity. That would be a priority for your patient. All right, guys, we're down to our last question. During the care of a patient post-total thyroidectomy, the nurse notes that the patient exhibits a positive Trousseau sign. Which illustration reflects this finding? There are two illustrations. Which one would reflect the Oh, I'm sorry, there are 3 illustrations. Which one would reflect the finding? And the correct answer is the one with the blood pressure cuff, and you see the hand going like this. That is Trousseau. So that's a type of tetany. What happens is when the patient has hypocalcemia, they're at risk for tetany. We'll see an increase in the nerve irritation, muscle spasms, and so you'll see their hand going like that. That's Trousseau's. Now, I want to go back to the question. They tell us the patient had a post-total thyroidectomy. Whenever you see thyroidectomy or parathyroidectomy, something's been messed with either the thyroid or the parathyroid gland. One of the things you need to be thinking about is calcium, because that can cause hypocalcemia. Hypocalcemia can cause tetany. So that's the correct answer. The first the picture with the person touching the person's cheek, that is Chostek. Chostek starts with a C, and so does the word cheek. When you touch their cheek and they go like this, right? That is a type of tetany called Chostek. And last is the picture of the woman with the bulging eyeballs. That's called exophthalmos. And then you look at their neck, you see a bulging neck. That's a goiter. By the way, the goiter, you can see that in hypo or hyperthyroidism. That bulging eyeball, you can see that in hyperthyroidism. So those were the wrong answer choices. But again, that hand you see going like this with the blood pressure cuff, that is a positive Trousseau sign. And that is the end of this video. Guys, please in the comment section, let me know what you thought about this video. Let me know if you'd like me to cover more endocrine disorders, because there are more endocrine disorders. I really haven't been able to go in depth, but let me know if you'd like to see more of that. And be sure to check out my website, nexusnursinginstitute.com. Lots of great resources for you there. Almost daily, you can find me on almost daily, you can find me covering a variety of questions across my social media platforms such as TikTok, Instagram, Facebook, of course, here, YouTube. My handle is the same everywhere, Nexus Nursing. Thank you for watching. You guys will catch me on the next video.